Hi, and welcome back to Module 3, Lecture 1, Part 2 for Community Health Advocacy and Social Movements. Last time we were talking about primary care for vulnerable groups, and we took an example of Kushal's article from 2015 about veterans experiencing homelessness and how their utilization of primary care services went up after basic interventions that mostly involved um, education and motivational interviewing and transportation. So tackling some of the very basic barriers that uh, people living in poverty face, and just seeing how these both low-tech and low-cost interventions increased utilization by a huge amount. So the financial benefits of primary care, first of all, they do benefit us as patients and users of the health system by lowering costs through prevention of future events um, for the patient or for the community, um, through preventing emergencies, prescription medications, if diseases can be caught before the process begins, um, referral to specialists. If we never get an advanced form of a disease, we never need to see a specialist. Diagnostic testing, which can be really, really expensive. An MRI in America and the United States or an X-ray are quite expensive. Surgeries, definitely expensive. If not for the patient, if they have Medicaid, it won't be expensive for them, but it's expensive to the health system. And it's also tough. It's recuperation, it's time off work, it's all these emergencies or chronic conditions or even acute forms of disease are time consuming, expensive, painful. So they have a huge benefit to individuals and communities by catching diseases early and prevention. Um, so people who have a primary care provider save 33% on healthcare compared to patients who exclusively visit specialists. And you may think, who does that? But I have seen um, people that I know who only visit specialists, and I think they either have to have really top of the line insurance or a lot like very deep pockets. Um, so costs of neglect. I just put this up there because it's not always us neglecting ourselves. As we saw in the textbook, sometimes health providers neglect their patients and tell them to go home. Sometimes they misdiagnose. Sometimes things like that can happen. So in whatever sense, whether a patient or a community or a provider is, whoever is neglectful in preventing disease, the costs of treating patients in the emergency department can be 4 times as much as other outpatient care when it becomes an acute problem. And a study in a North Carolina emergency room showed that nearly 60% of health issues could have been addressed in a primary care clinic earlier, um, at an earlier stage, and estimated savings for those kind of treatments were 320 to 720%. So it would have been 3 to 7 times less costly to treat that patient at an earlier stage. So chapter 3, just getting to your book, as I said before, I love that this lecture on primary care intersects with chapter 3 of your book, which is about the People's Free Medical Clinics. So two questions I have here are, what were the needs and gaps that Bobby Seale wanted to address with the People's Free Medical Clinics? And I'm talking about pragmatically, not politically. There's lots of political rhetoric in this book, and I'm not talking about that per se. I'm more talking about the actual gaps in healthcare or in, geographically or anything like that, that they actually wanted to practically address. And then the other question is, how did the Black Panther Party address primary care gaps in their own community? So some of the responses, like on looking at it on a bigger level, I would say uh, by honoring non-expert or community wisdom was one way that they approach the primary care practice that they were doing by opening the free clinics. They had expert medical volunteers training community health workers. So they had experts who were doctors and nurses and health providers training volunteers who became community health workers, went out into the community, educated people about their health conditions, about primary care, about prevention. So this was a huge thing that they did. They employed patient advocates, and when I say employed, they were all volunteers. So they utilized or trained patient advocates. Cleo Silvers was one of them. And these patient advocates helped community members with matters of physical health, housing issues, legal aid. So what your current day social worker what you might think of like that, these were the patient advocates who were party members, volunteers, professionals in their own right and maybe in different professions, but they were volunteering as patient advocates. And teaching self-help. So this chapter really dives into this self-help philosophy that the party was teaching to the community members. And they had activities such as cervical self-examinations and ways to empower their patients to take charge of their own health and gain awareness and understanding and power to take care of themselves and know about their own health. So this chapter sort of goes deep into what the medically underserved communities were facing, which were inadequate facilities, negligent care from doctors in segregated or desegregated hospitals, specifically mostly the teaching hospitals. They were getting negligent care, paternalistic and sexist medical authorities. And the book talks about that a little bit in chapter 3, how there was sort of a both race and gender kind of dynamic in the medical profession, which you still might see it today, but back then it was pretty harsh. So that was there for patients trying to access care. The distances from Black communities to hospitals were tremendous. They definitely weren't walkable for some communities. So the lack of access in terms of distance, they were unaffordable and profit-centered, and Chapter 3 addresses that as well, and how the hospitals were very much for-profit models in some of the communities where PFMCs were built and established, including Seattle. Attending doctors were disrespectful, and the students were too. And so that was part of what they were facing, that it was hard to just even go to a doctor or even the medics and any health provider interfacing with the Black community were generally disrespectful. And unless you start talking about the more radical health professionals and um, the Haight Ashbury Clinic and the Counterculture Clinic, and then you start getting into these other health establishments which were engaging in the non-expert wisdom, and they were respecting patients, and that was a different paradigm altogether back then, which was, radical, but what we think of it today as being decent. So anyway, there was also unethical experimentation going on, which you can understand why people didn't want to go to those hospitals, having to have the fear of this. And then there was, as Nelson writes, spatial segregation and psychic distance. And I mean, literally segregation. So there was that. But psychic distance was kind of the mental distance, like how we as community health professionals and providers and advocates want to be close to our community and know them and understand them and help them. There wasn't that going on. So that's what I feel she was referring to with the psychic distance. Social health approach. So they were also focused on circumstances surrounding illness, healthcare as a human right rather than as a commodity, building a bridge of understanding between the community and experts, which I mentioned in the previous slide, the re-education of health professionals on culture and philosophy. And this might have been reading the books that they saw as radical, just talking about more equality, equity, these concepts that we now strive to achieve. That was being kind of a countercultural back then. Demystifying medicine. They built a multifaceted community with all kinds of groups, coalitions, organizations, people, students, doctors, community members, everybody. They were changing the institutional and interpersonal practice of medicine, utilizing any resources available. You saw the Boston PFMC was in a trailer, so no cost, low cost budgeting. Democratization of their movement, of their clinics, of their health network, group decision making, and being non-judgmental. So the important people, I'll just go over it quickly in your chapter, were Cleo Silvers, you know about her. Norma Armour, sorry I left that blank, but she is a health advocate as well. I don't know her credentials in particular, I might have to look that up. There was Ray Masai Hewitt, Minister of Education. Terry Coopers was an MCHR physician. Nelson Malloy from the Winston-Salem chapter, Erica Huggins, and Kathleen Cleaver were party members and also heading up these kind of programs within the party. Asada Shakur, you might have heard her name before. She's now an asylum seeker in Cuba because she is running away from law enforcement here in the United States, but she was head of the Liberation School, one of the schools, and one of the free breakfast programs. Tolbert Small was the party's medical director for some time and wasn't officially a part of the party, but he really helped out a lot in establishing the clinic in Berkeley. And David McClenahan was one of the MCHR doctors that they met up with, but I'm so excited to tell you that he was on our community health interview list, and one of your classmates did interview him. He lives in West Seattle, and it's really cool to know him. So anyway, have a great week.